The faculty and the star instructors apart from me are, I will be taking you through the preoperative planning and workup of phakic lens. Then Dr. Partha Biswas on the left. It's not coming on the screen, it's going out of screen. Can you realign this? Yeah, thank you. Dr. Partha Biswas, you all know him well. He is the champion here today, and the master scientific program which he has created and crafted, I really appreciate. And he will be taking us through the correct way to do ICL and toric ICL. Then Dr. Ramamurthy will be taking us and phakic IOLs, the Indian phakic IOLs, his experience. Then Dr. Sri Ganesh will be with us soon, and he will be taking us the lenses, phakic lenses in challenging situations and how to come out of this, how to overcome the challenging situation. And then Dr. Sudhank Bharti will be taking us and we'll be discussing on the managing complications and pearls to avoid in phakic lens. So this is in the nutshell, and all the faculty, all the instructors are very, very experienced. They have a long track record. They have an experience of almost 20 years of doing phakic lens. I myself have an experience of almost 18 to 19 years. We started our journey with the very size phakic lens, which was PMMA lens, which was placed in the anterior chamber. So coming to the preoperative planning and workup of phakic lens, I don't have any financial interest. Phakic IOL, we all know, and is an intraocular lens placed inside the eye in front of the patient's natural lens to correct the refractive error. These are available in three types as per their site: angle supported, iris fixated phakic lens, and the posterior chamber phakic lens. This posterior chamber phakic lens are the most popular and effective mode of correcting the myopia and hyperopia at present, and we will be focusing our course on this type of phakic lens only. So before taking you further, this is a 45-second video of the star Vision ICL. This comes in a bottle in a BSS solution, and with the soft tip plunger, you take it out from the bottle and place it in the cartridge, load it. This is a front loading system, and inject it in the eye. I use viscoelastic. Some people don't use viscoelastic in the eye, but the recommendation from the company, and I will also suggest, is if you are going to start, then use viscoelastic in the eye. And this is a toric lens, and you align it with the axis, and it doesn't take much time, less than the time we take for the phacoemulsification, and the results are very gratifying. So with this, the history, the quest for the phakic lens began since 1953, and various kind of lenses have been designed, used in last, almost 60, 70 years. These are the available lenses, and this lens took us, this iris fixated very size phakic lens, which we all, the faculty have used in the past, and this was some 10 years, 12 years back we used to use, but they were iris enclavated lenses, and in the anterior chamber, the chances of damage to the endothelium and disenclavation and the development of cataract, all these were there with this, and this has come in the form of foldable IOL also later on as a reflex lens. Then almost 8 years back, Acrisoft came out with a cachet lens, but this also didn't pick up the market, and because of the placement of the lens in the anterior chamber. So in 1986, I think this was the time when Fedorov gave us the idea for this present generation lens, which was to be placed behind the iris in the sulcus, and this was the prototype of the present generation lens. The advantages of posterior chamber phakic lens is that it lies behind the iris. It is far from the endothelium. The chances of endothelial cell loss is very less, because damage to the cornea is more unrewarding thing in a young patient. than development of a cataract. So cataract, we all know we can do it. We are doing it at a pediatric age group and all age groups, and when it is there, and we get a good result, and we can come out of it without permanent loss or permanent damage to any structure. But damage to the endothelium is more unrewarding. It gives us an excellent cosmesis. It is close to the nodal points of the eye. Gain in the retinal size images because it is close to the nodal point, and there is greater effective optical zone at the corneal plane. We get so field of vision is better, and there's the less chance of glare and halo. And because it is located in the sulcus, it's a stable location. We can have a toric design, and we can correct the cylindrical power also easily, and with good results. Easily removable, exchangeable. When the cataract develop, you can remove it, and you can explant it. That is the one of the finest part, that like the corneal based surgery, you are not making the cornea thin, and later on the IL power calculation also is very, very easy. So there is no fixation to the iris tissue, so there is less chance of lens disenclavation and other problems. Does not alter the shape of the cornea or remove the tissue like in any other corneal based problem. The shape of the lens, which I will be focusing here on the ICL, because I have maximum experience of using this lens only. It is an implantable polymer lens. It has a central vault. As you can see, there is a convexity, and this convexity has to be placed anteriorly. It should match with the convexity of our crystalline lens. So the design is such that the haptics on the either side, they rest in the sulcus, and still they are away from our crystalline lens. And the central part, as you can see, it is aligned, or it is matched with the crystalline lens, and the design is such that it always remains away from the crystalline lens, and therefore the chances of development of cataract is very minimal. And this is a plate haptic kind. It is a foldable lens. It absorbs ultraviolet radiation. But the important thing here is that there is a sizing issue, which we'll be taking into our later slides, and it is made up of a polymer material. So advantage of this material is that polymer material is that it attracts a fibronectin. Can I have a pointer? So it attracts a layer of fibronectin on the surface of the lens. This minus this thing, what you can see, it is on the surface of the lens, and it repels the proteins which are present in the aqueous. So this fibronectin layer, it's not working. So it repels the proteins. So there is the lens material remains clear for a longer time, and this is not recognized as a foreign body. So you can compare the bottom slide. The polymer material is on the left and the silicon is on the right side. The polymer material clarity you can make out in this slide. And this, therefore, there is a maximum light transmission. It's not working, the printer. Molecular size is 100 nanometer. Shorter than wavelength of the light. That's why there is a maximum light transmission, better optical performance. Please come on the dais, Dr. Ramamurthy. Please, here. Please come. Better optical performance, excellent transmittance, and low refractive pattern. Very, very flexible, foldable, small incision. It can go inside the eye, and easy to inject and easy to remove. And there are less glare and halo issues with these lenses. They are available in the spherical power from minus 0.5 to minus 18 diopters, and with the toric correction of plus 0.5 to plus 6 diopters. And in the hyperopic, it is from 0.5 to up to plus 10 diopters. And they come in steps of 0.5 diopters, 0.25 diopters from 0.5 diopters to up to minus 3 diopters, and in a step of 0.5 diopters from minus 3 to minus 18 diopters. And they come in various lens sizes, 11.6, which is rarely used, and 12.1, 12.6, and 13.2. These are the maximally used lens sizes. And it has the new generation for the lenses has got a Centra Flow ICL. It belongs to the category of ICL V4 family. There is a central opening of 360 microns, and it is designed to restore the natural aqueous flow into the anterior chamber from behind the lens and the posterior chamber to the anterior chamber, and it eliminates, therefore, it eliminates the need for the iodotomies. There are two paracentral ports of the same size on either side, and these two ports help us to facilitate us to equilibrate the aqueous in behind and anteriorly, and at the same time it helps us in removing the OVD from behind the lens during the procedure, and it provides redundancy if perchance the central opening gets occluded due to the proteins in the anterior chamber, like in iridocyclitis or anything, then these paracentral ports can act as a redundant ports. So the newer EVO Vision ICL comes with a larger optic diameter, which is from 4.9 now to 6.1 millimeter, and from minus 0.5 to minus 9 diopters it is 6.1 millimeter, and this gives us better quality of vision and less chances of glare halos when we are driving at night, and that is the beauty of this lens, and similarly in the toric variety also. Now coming to another counterpart, that is the Indian lenses, which we all are also interested into, and Dr. Ramamurthy will be taking us along with the journey with his experience of Indian lenses. So they come, the good part is they come from -1 to up to -30 diopters. So you can, without doing LASIK or anything, you can correct more power, and in the hyperopic side, it is up to +15 diopters in a 0.5 diopter steps, and you can correct up to +10 diopter cylinders of the patient. They come into, now they are coming as a multifocality lens in presbyopia for the correction of presbyopia with +1 to +4 diopters of correction of near. So optic diameter is larger than with the ICL, that is 6.60 millimeter. Overall length is better because it comes in a steps of 0.25 millimeter. So this is more accurate, and you can manipulate the vault in a better way. So vault height which we get is 1.2 millimeter up to 1.8 millimeter, but this vault height should be depends on the size of the lens and the depth of the anterior chamber and wide to wide diameter. So this is a presbyopic lens from the Indian company, and it corrects the presbyopia. It is placed in, like any other phakic lens in front of the crystalline lens. Coming to the workup part, which is most important thing, it is most of the things are same as we do it in any other refractive case. Age group is 21 and 40 up to 45 years of age, which is recommended. We should have a stable refraction. There should be less than 0.5 diopter change in last 1 year. It is good for the LASIK rejects due to high myopia, which could not be corrected by the refractive procedure like SMILE, LASIK, femto-LASIK. If the corneal thickness is less than 500 micron, there is a severe dry eye or some amount of dry eye is there. When the pupil size is large, or when there is excessive flat or very steep corneas are there where we cannot do LASIK, in such cases we should look for the phakic lens. And there is no previous ophthalmic surgery, which is a relative contraindication because we do now for the treated keratoconus cases. And there is no previous ocular pathology like presence of cataract, glaucoma, uveitis, keratoconus, Fuchs dystrophy, or any other corneal pathology. A complete ophthalmological examination is done beforehand. Uncorrected visual acuity, best corrected visual acuity, refraction, manifest and cycloplegic, slit lamp examination, intraocular pressure, no glaucoma, open angles grade 3 to 4, corneal topography and keratometry has to be done in all these cases. We should not say that topography, because we are not doing cornea-based procedure, topography should not be done, but we request you to get the topography done in all these cases. Endothelial cell count should be more than or equal to 2000. Fundus examination, especially the peripheral retina, should be evaluated in all these cases because there is a high chance of development of detachment if there are precursor lesions in the retinal periphery. And the two important things which are different are the measurement of anterior chamber depth, which should be more than or equal to 2.8 millimeter. Better it is for the RD cases, it should be more than 3 millimeter, which should be the excluding the corneal thickness. And second important thing is the wide to wide distance measurement, corneal horizontal wide to wide. So anterior chamber depth is that many machines, they give us anterior chamber depth including the corneal thickness. So minded, we have to reduce the corneal thickness like IOL master and other things, and even pentacam. If you are not selecting the internal measurement, then you will get a thickness of anterior chamber depth including the cornea. This should be from the posterior surface of the cornea, internal anterior chamber depth. Wide to wide measurement is very, very important because it varies from patient to patient, and our end results are based on the measurement and the quality of wide to wide we have measured. Although it is simple, the reliable way is to measure by the caliper, and we should counter check it with the help of a ruler. But nowadays we are using the bottom one, the digital caliper, and this is much better, and this is more in practice nowadays. Apart from digital calipers, we can measure wide to wide by following by the instrument like Orb scan, Pentacam, IOL master. UBM gives us sulcus to sulcus, the internal measurement where the lens is going to be placed, but it has not been in practice, and it is not popularly used because the availability of UBM is also not there, and there is the change is there by the various operator if they are using it. A vernier caliper under microscope can be used, and some advanced autorefractometers also give. This is the measurement of wide to wide by the IOL master 700. You can get it, and it measures it. It is near to it but not accurate, and this is the internal sulcus to sulcus measurement on the right side. So how to do it? Measurement should be done under the microscope and in a higher resolution, as you can see here with the digital caliper we are doing in a supine position, and from the middle of limbus to the middle of limbus on the other side. So this gives us the digital value 11.16 in this particular eye, and we should calibrate the caliper before we use it. These are important. So coming back to the AC depth and use of wide to wide, the accurate preoperative wide to wide and AC depth measurement is important because it gives us the what size of ICL which we are going to use, whether it is 12.1, 12.6 or 13.2, and because this ICLs provide a vault, and vault is what? It's a distance between the posterior surface of the lens ICL and the anterior surface of the crystalline lens. So this is what we have to measure, and this is what we have to see on the slit lamp. And ideal sized ICL gives us a vault of 0.25 millimeter to 0.75 millimeter. That is, if you assume the thickness of the cornea to be 500 micron, so this should be half the corneal thickness, which is 0.25, 250 micron, to 1.5 times the thickness of the cornea. So an undersized ICL will increase the risk of anterior subcapsular cataract if it is less than 0.125 millimeter vault, and an oversized ICL will push the iris from the periphery anteriorly, and there is a chance of closure of the angles which could lead to rise in the intraocular pressure. So this is what we have to see. This is a picture which we have taken from the net. This is the green one is the anterior surface of the ICL. Yellow arrow is the posterior surface, and the red arrow is the anterior surface of our natural crystalline lens, and the distance between yellow and red arrow is the vault, and this thickness which can be seen on slit lamp, it should be compared with the thickness of the cornea, and within 2 seconds you can judge it whether post-operatively whether your ICL is properly placed and the sizing is proper or not. And in this particular case, it is very less, and the lens is resting on the surface of the lens in the periphery, as you can see. So this patient will develop the cataract in early post-operative period. So this is the sheet which comes And this is how we assess. In this particular case, the patient, uh, patient's power is minus 11.5 diopters with the minus 1.5 diopters of cylindrical, and X is at 10 degree. K1 keratometry we are entering. Anterior chamber depth is 3.22 millimeter, which we have measured. Corneal thickness is 526 micron. White to white is 10.70 millimeter. And this is the lens which is suggested and which we have checked it. It's because the white to white is 10.7, the lens size is 12.1 millimeter, and it is the power of the lens is plus 14.5 to with plus 1.5 diopters of cylindrical, and this will the expected residual refractive error, which is shown over here, and the lens serial number also we should see on the day of implantation of the IOL. We should check it. This is another case, like why we didn't do refractive procedure lens, these cornea based refractive procedure, because the corneal thickness is less, 487 and 483 in the left eye, and the power is although low, but still patient preferred to go for ICL because of the advantages. The contrast sensitivity is better, the aberrations induced are minimized as compared to the lens based procedure, and so that's why patient chose the ICL over the cornea based refractive procedure. Another case with minus 9 diopters of spherical correction, white to white is 11.80, lens size is 13.2, and this is the residual refractive error. So this is a clear case. On the other eye, in the other eye it is 10.25, and the corneal thickness is less. So this is this cannot be operated by the cornea based procedure, refractive procedure. So we have opted for ICL in this particular case. Another case with the minus 4 diopters of refractive power, but the corneal thickness is 479 and 489. That's why we chose this ICL for this particular case. And this is an interesting case, minus 7.25 in the right eye with minus 3.50, post C3R, post corneal collagen cross linkage patient for the keratoconus. 1 year later we operated because the thickness of the cornea is very low, 398 in right eye, 437 in left eye. So these cases also can be corrected and can be managed easily by this lenses. And this is the Indian counterpart IPCL from the care group. I have no financial interest, and this sheet comes in a similar way for these patients also. So at the end, this is the recent data which tells us the 8-year outcome of implantation of posterior chamber phakic intraocular lens with a central port for moderate to high ametropia. This has come into publication in December 2021, and from a Japanese authors, and you can see at the most of the patients, they achieved 80% of 6/6 vision, which was there at first year till the 8th year. Almost 80% of the vision was there in all these patients, and 6/9 vision is almost in 90 to 95% of the eyes. So so it is stable, and there is no development of cataract because of the central port and centraflow. Centraflow design, the incidence of cataract has also reduced, and even if there is a low vault around 250 micron vault is also there, that is also we get a extra edge, and we are forgiven because the chances of development of cataract are less. So thank you for your patient hearing, and any questions? We can take it now or maybe at the end of the session.
Is there any Japanese company making ICL?
I don't have any idea, but a Star is the only FDA approved lens which is making this, and others are from the Indian side. Please.
About ICL, I think the thickness and the diameter of ICL is foldable.
Yeah.
Plus minus looks like the traditional foldable IOL. Can we do an injector, simple injector, like the
This comes because this ICL, they tell us to use their full injector system only, and the front loading system of loading the lens.
I know, I use it.
Indian
I was
lenses,
asking.
I have not used that. Indian lenses, they are used in the same cartridge what are being used for the normal intraocular lens, and their incision size is also 2.65 to 2.8 millimeter. The incision size required for ICL is 3 millimeter or more. Yeah, but I have no experience of using with the regular cartridge because they require a soft tip plunger. Material is different. It's made up of polymer material. Your experience, Dr.
Yeah, as far as ICLs are concerned, because the injector comes along with it and then custom made for that, it goes in very comfortably with that. I think that it's extremely soft and thin, and you do not want any overriding of the plunger onto the optics of the lens, which will damage it. So I think we have never tried injecting it to anything else because the injector is always supplied with the ICL.
Do you add some solution with the viscoelastic? Because all the visco should be totally clear.
Actually, this part will be taken by Dr. Partha, but for your this thing, what we do is we put some BSS in the cartridge first, and some amount of viscoelastic OVD is then added to it, so it dilutes, and then we place the lens over it, and then we fill it with the BSS after that also. So more of BSS and less of, or 50% of BSS and less of OVD.
There's a small difference in the way we use ICLs in the Indian lenses. As far as ICL is concerned, as Dr. BHASIN mentioned, you can just use HPMC or a combination of a little bit of saline. But when it comes to Indian lenses, it's better to use just saline or to avoid using HPMC. Whenever I use HPMC with that, initially I used to get some cuts on the lenses, and that's avoided once you load it only with the saline, because they seem to work better with that. And as regard, just a small comment, you said that ICLs can be used for any kind of cases, including keratoconus cases. I agree with you. But it should be, you have to make sure these cones are centered cones. And the patient is having an excellent best corrector visual acuity with glasses. If supposing the patient has a decentered cone and requires contact lenses, a hard lens or a rose scale lens for the correction, then it's better not to put a ICL in these situations, because lenses, the phakic lenses at best is just a replacement for glasses, and they do not correct the aberrations on the corneal surface. So in case you are putting in phakic intraocular lenses in keratoconus or iatrogenic keratoconus cases after they are stabilized, make sure that the patient has a good vision with glasses and does not require contact lenses.
And other thing is the measurement of white to white and the anterior chamber depth in post keratoconus eyes. So anterior chamber depth is also higher in post keratoconus eyes because of the presence of keratoconus. That there is false increased depth will be there. So
Any comparison of this BioCare and Care Group lenses?
Dr. This thing, Ramamurthy will be speaking in his talk. Dr. Bharti, you are there. Please come on the dais. Welcome. So, any other question, or shall we take? Results are same. You have to do PI in these cases, one, and secondly, in hyperopic cases, the anterior chamber depth, usually you do not get adequate anterior chamber depth. So that's why. But if you have an adequate anterior chamber depth, then it gives a good result. The outcome is good. Not in all cases, in hyperopic cases, because they are without the central flow. They don't come with the central opening, hyperopic lenses. But the results are equally good. On dot refractive correction.
Do you have any experience with presbyopic ICL?
I don't have any experience. I think Dr. Titial has and Dr. Ramamurthy has some. Please, if you can add.
No, one regarding the hyperopia and ICLs. I think, it's a bit of a misconception that all hyperopic eyes have small ACDs. I mean, right from Jack Holliday's work, almost 80% of the eyes could end up with a fairly good anterior chamber. And especially laser vision correction doesn't work well with hyperopia beyond +2, +2.5 diopters. So whenever there is adequate anterior chamber depth, we go ahead and for anything beyond 2.5 diopters, ICLs is my first choice. And it works very well. There's absolutely no need for a PI if the AC depth is quite adequate, because there is a need for a PI in all these cases, because hyperopic lenses do not come with a central hole, because these lenses are fairly thick in the center, and it's difficult to create a hole in the center. And secondly, because the thickness of the optics, they would cause unacceptable aberrations. So all hyperopic lenses come without a hole, so you have to do a PI in these cases. As far as presbyopic lenses are concerned, I'm going to be briefly referring to it during my talk. They are basically trifocal lenses that are available, and they come from an add of 1.5 to 3.5 diopters. It's distance, intermediate, and near. And Star has also come up with their version of EDOF lenses. As of now, it's not available in India, but I think it's already available in Europe, and we are looking forward to it becoming available soon. I think I find that that's again an excellent modality for correction of refractive errors.